Hi, welcome to this online lecture. During this lecture, I'll provide an overview of substance use disorders, beginning by sharing some of my experience working with clients who struggle with substance use. I will then talk a bit more generally about some key concepts related to substance use, talk a bit about how people might develop struggles with substance use, as well as talking about some other key issues related to treatment for people who struggle with substance use disorders. So I'm going to begin this discussion by talking about some of the clients that I worked with and some of my experience working with clients with substance use problems. Much of that work occurred during an internship I completed during my last year of graduate school at a VA medical center in the Boston area. Most of my work there was spent in a long-term residential treatment program for homeless veterans also struggling with substance use. This was a recovery-oriented program, so the main goal of the program was to help veterans maintain sobriety and also help them with any other mental health problems they might be struggling with a focus on helping them gain access to housing, gain employment, repair social relationships, and recover in the context of substance use and increased well-being and quality of life. Veterans in this program, again, it was a 100-day program. Veterans in this program first completed medically supervised detox after discontinuing use of whatever substance they might be struggling with. About half of the veterans in the program struggled with alcohol, and a vast majority of the other half of veterans in the program struggled with opioid use, which we'll explore more later here in this topic. As part of the treatment program, veterans had weekly individual therapy sessions. They met weekly with social workers. They attended group therapy sessions pretty much every day throughout the week. Many of the veterans also attended AA or NA, Alcoholics Anonymous, or Narcotics Anonymous meetings. They also met with recreation therapists as part of the program. So each day, veterans would participate in a variety of group or individual treatment. Also, as part of the program, they would work through supported employment. So we have partnerships at the VA with several employers in the area. So veterans in the latter half of the program would work in the supported employment program. And then near the end of the program, we would work with veterans to connect them with housing after their stay in the residential treatment program. This treatment program, I think, is a really good example of modern substance use care that is recovery focused, where the goal of treatment is not merely to maintain sobriety, but instead to provide comprehensive support that helps people build lives worth living, to work on repairing social relationships, maintaining employment, maintaining housing, critically important supports in the recovery process from substance use. I want to share an example, a case example of one specific client that I worked with. I've changed a few details about this example. I've changed the name of this client to maintain confidentiality. But this is, I think, a good representative example of struggles with substance use, especially as it relates to opioids specifically. So I want to share and begin our exploration of substance use disorders by sharing the story of Andy, a client that I worked with who participated in the residential treatment program. Andy was in his late 20s and struggled over the last several years before entering the program with heroin use. Andy's struggles with mental health problems more generally began early in life. Like many people who struggle with substance use disorders, Andy experienced trauma early in life. He experienced sexual assault by a clergy member at the church that he attended as a child. That abuse continued for several years, and Andy did not tell anyone about that. Even as of his time in the treatment program several years ago, Andy had not shared that experience with his family members. As you might imagine, experiencing profound trauma early in life severely disrupted Andy's development of his sense of self, his sense of safety and security in the world, his ability to trust other people, to form relationships with others, changed how he viewed himself, disrupted his emotional development. Think back to the topic where you learned about developmental psychopathology and how early trauma in life might disrupt healthy development in social relationships, psychological development, cognitive development, and that happened for Andy. Despite the adversity that Andy experienced as a child, he completed high school and was relatively successful academically. And upon turning 18, he decided to enlist in the U.S. Army. Andy served in the U.S. Army for several years and was deployed several times during his military service. Like many people who serve our country in the military, Andy struggled with chronic pain as a result of his military service. As you might imagine, from injuries and also just from the physical demands of military service, it's not uncommon for veterans to struggle with chronic pain after discharge from the military, and Andy did. Andy received care, medical care at the VA after his discharge from the military, and mentioned to his primary care physician at the VA that he had been struggling with pain. After trying several strategies to help him manage his pain, including medications such as ibuprofen, as well as some other approaches, Andy's doctors discussed with him the possibility of using opioid pain relievers as a way to manage his chronic pain. It was explained to Andy by his primary care physician that a relatively new opioid pain reliever called OxyContin was an option for helping him manage his chronic pain. This is a medication that was marketed as being non-addictive. Now it turns out that that medication actually is quite addictive, as you're going to learn about some when you learn about the opioid addiction crisis later here in this topic. But Andy was assured by his physician that this medication had a relatively low risk of addiction, and it might help him manage his chronic pain. Andy was prescribed the opioid pain reliever and began taking the medication as prescribed. It adequately helped him manage some of his pain. It wasn't perfect in that, but it did lower the degree of physical pain that he felt. But in addition to modulating experiences with pain, opioid pain relievers such as OxyContin can also have relatively profound psychological effects. They can lead to feelings of euphoria, and they can also help people escape and numb psychological pain that they might be experiencing. And that was the case for Andy. He explained during the course of treatment that when he was taking opioid, and began again with the opioid pain relievers, when he was taking opioids, that was one of the few times that he felt some relief from some of the psychological struggles that he was experiencing as a result of his childhood trauma and the resulting PTSD that he struggled with throughout most of his life. Like many people who take OxyContin and similar opioid pain relievers, Andy quickly developed tolerance for the medication, needing more and more of the substance to experience the same levels of relief, both from his physical pain and his psychological pain. He also began experiencing some withdrawal symptoms in advance of taking his next dose of the medication. In other words, he had become physically dependent on the medication. In and of itself, that's not necessarily a problem, but for many people who become physically dependent on a medication, such as an opioid pain reliever, Andy found himself taking sometimes double doses, sometimes taking a dose early. to the point where he would begin to run out of the medication before his next prescription was available or the next refill was available. Early on, this was not necessarily a problem. His physician, told him that this is not something that's uncommon, so he would, go ahead and call in a refill for Andy. But over time, Andy began to run out of the medication earlier and earlier and take the medication more and more frequently, again, as he continued to develop higher and higher levels of tolerance. It reached a point where Andy was unable to refill his opioid pain reliever and was beginning to experience profoundly aversive withdrawal symptoms, both physically and psychologically. Opioid withdrawal is both physically and psychologically an incredibly difficult experience. It can lead to people feeling high levels of psychological distress, as well as quite a bit of physical distress, including rather painful gastrointestinal symptoms. Especially at the time in the area that Andy lived, heroin was relatively widely and cheaply available. Through some social contacts, Andy was able to acquire some heroin and began to use heroin. And this is a very common pattern. In fact, research suggests that upwards of 80% of people who struggle with heroin use begin using heroin in the pathway that Andy did, being originally prescribed opioid pain relievers. Andy began to use heroin as a way essentially to bridge the gap between when his prescription of opioid pain relievers would run out and when he was eligible for a refill. I want to note a few things here about Andy's case at the moment. So number one, through no fault of his own, Andy experienced trauma as a child, something he didn't choose to have happen to him. That disrupted his development, psychologically, socially, his sense of self. He was served his country in the military, experienced pain and struggled with chronic pain as a result of that, and was told by his primary care physician at the VA that the medication he was prescribed was safe and effective. It was not safe. Andy developed an opioid addiction as a result of that prescription. And really through no fault of his own, without choosing to seek out using opioids in the first place, Andy developed an opioid addiction, began to misuse opioids, and began to then struggle with heroin use. Andy continued to develop higher levels of tolerance, used more and more heroin, and his struggles then with heroin use began to cause additional problems in his life. Andy found himself out of work. He found himself struggling to maintain healthy social relationships, and he experienced several overdoses, one of which almost cost him his life. He was in and out of the inpatient psychiatric unit and the emergency room at the VA hospital a few times after a couple of overdoses before agreeing to enroll in the residential treatment program following an overdose. Andy was then in and out of that residential treatment program several times before completing the program for the full 100 days and then gaining employment and housing after his time in the program. As I mentioned, Andy's case is representative of the vast majority of people who struggle with opioid use. The vast majority of people who struggle with opioid use begin that from being prescribed opioid pain relievers. As I mentioned, when you're going to watch a documentary and complete an assignment about the opioid addiction crisis, you're going to learn more about some of the fraudulent research and marketing related to OxyContin and other opioid pain relievers, and the ways that opioid pain relievers were and at times still are prescribed, in addition to the ways that specific drug and related drugs were marketed and disseminated, contributed to the opioid addiction crisis that we're experiencing currently and have been experiencing for about the past 20 to 25 years. Upwards of 100,000 people lose their lives due to drug overdoses in the United States each year. A vast majority of those come from opioid overdoses, where people use, often accidentally, in fact, overwhelmingly accidentally, too much of a substance and can experience overdose and, in some cases, death as a result. Currently, the opioid addiction crisis has shifted into a relatively new and far more dangerous phase, with increased availability of and use of fentanyl, and a synthetic opioid that is also an opioid pain reliever, commonly prescribed for people experiencing post-surgical pain and people experiencing cancer and cancer treatment-related pain, as well as being used in end-of-life care. Fentanyl plays a critical role in those medical treatments. However, fentanyl is very easy to overdose on because it's an extremely potent opioid, and taking just slightly too much or unknowingly taking fentanyl, as it's commonly mixed with other drugs, can easily result in overdose and death. And that's been driving a recent increase in overdose-related deaths. So now that we've talked a bit about opioid addiction in this case example and touched a bit on the opioid addiction crisis, I want to shift our focus to talking a little bit more about substance use disorders in general. I'm going to review some key concepts related to substance use and then talk about substance use disorders specifically. So first, key concept number one is substance use. Substance use involves, quite simply, the use of a given substance, whether it's an opioid or a stimulant or a depressant. Substance use is quite common. The most commonly used substance in the United States, for example, is caffeine. Caffeine is a psychoactive substance. The ingestion of caffeine leads to changes in behavior, mood, cognition, and emotion. And upwards of 90% of Americans use that substance every day. In fact, I've got some caffeine right here. Another important concept related to substance use is intoxication. This is where there is impairment in behavior or cognition as a result of substance use. Believe it or not, it's possible to experience caffeine intoxication. It's hard to do from drinking coffee. You could probably make some really strong coffee and maybe get close to experiencing caffeine intoxication. But if people take enough caffeine, primarily through caffeine pills, there can be pretty severe psychological or physiological, effects as a result of that. Another key concept related to substance use is tolerance, which involves taking more and more of a substance in order to achieve the same effects. Over time, my caffeine use has absolutely led to tolerance for that substance. I need more and more caffeine to achieve the same level of alertness and to stave off withdrawal symptoms that I experience, another key concept related to substance use, if I stop using caffeine. So I'm pretty irritable in the morning before I drink coffee, and if I tried to stop drinking coffee, I'd have pretty bad headaches, examples of withdrawal symptoms. Typically, when people experience physiological withdrawal and tolerance together, we use the term dependence, physiological dependence, to describe that state. I want to just point out that physiological dependence is not the same as struggling with a substance use disorder. So there is really no such thing as caffeine use disorder, because although I have developed tolerance for caffeine, needing more and more of the substance, although I experience withdrawal symptoms when I try to cease use of that substance, in no way, shape, or form does that get in the way of my life. However, when substance use begins to interfere with life, when it causes impairment or distress, people then might have developed a substance use disorder. In the reading here for this topic, you can look at the full set of criteria for substance use and related disorders, but I just quickly want to run through those. Substance use and related disorders are characterized by at least two of the following experiences, and again, don't worry about writing these down. The list of these are in that reading. Number one, increasing use. Number two, desire or unsuccessful efforts to cut down on or control use. Number three, people spend a great deal of time spent in activities trying to obtain the substance or use the substance or recover from its effects. People experience cravings or urges to use the substance. People continue to use the substance despite a failure to fulfill important obligations related to work or school or home life. People continue to use the substance despite experiencing social or interpersonal problems. People give up important life activities to continue using the substance. People use substances in situations where it might be physically hazardous, such as driving. People continue to use substances despite having knowledge of having negative physical or psychological impacts as a result of that. So, for example, continuing to drink alcohol despite knowing that that might be causing physical damage. Experiencing tolerance and or experiencing withdrawal. When people experience 2 to 3 of these experiences, that is considered a mild substance use disorder, with substance use disorder severity increasing with meeting more and more of those 11 diagnostic criteria. I want to point out that it's possible to experience many of these and not have a substance use disorder. I experience frequent cravings and urges to consume caffeine. I spend time trying to acquire caffeine. I'll go to the store and buy coffee. I stopped at the store this morning and spent some of my hard-earned money on multiple sources of caffeine. However, my caffeine use doesn't get in the way of my life, and it's not physically harmful. What differentiates non-problematic from problematic substance use is that interference with life and or distress about use or harm that might be caused. So I now want to shift focus to talking a bit about the causes of substance use disorders. Quite simply, substance use disorders begin with initial use of some sort of substance. Some research suggests that there might be genetic predispositions that influence how people might respond when initially using substances. This research is a little bit mixed, and as with some of the research related to depression, the genetic contributions are quite complex and involve multiple genes, gene-environment interactions. But the bulk of this research suggests that some people might be a little more susceptible to developing problems with substance use upon initial use. It's kind of impossible to know who might be in that bucket, if you will, and who might not be. But because of just random individual differences that are non-pathological in nature, primarily related to reward processing, some people might be more susceptible to experiencing stronger rewards when they use substances. Substances have predictable neurobiological impacts when people use them, including caffeine, for example. So when people use substances, our body, including our brain, adjusts to chronic substance use. So for example, if people use nicotine chronically, caffeine chronically, if people use opioid pain relievers chronically or alcohol chronically, there are predictable neurobiological changes. The body will essentially adjust to levels of that substance in the body, and can develop physical dependence as a result of those neurobiological changes. So just as an example, opioid pain relievers, when people take those, opioids bind to receptor sites on certain neurons in the brain and throughout the central nervous system. Now, importantly, our body naturally produces opioids. So, for example, during physical activity, depending on belief and expectations that people might have, depending on where attention is directed, our body naturally produces opioids that will bind to certain receptor sites on neurons throughout the central nervous system that have the effect of modulating and essentially blocking pain signals from reaching the brain. There are caffeine, for example, also binds to receptor sites to a variety of different types of neurons throughout the brain, including neurons that are involved in attention and memory and mood and cognition. When people use substances repeatedly, especially chronically, and those substances bind to those receptor sites, there are changes that occur as neurons adjust to elevated levels of those substances, and there are actually physical changes on the surface of neurons. When people use opioids chronically, one specific area of the brain, right about in the middle of the brain, involving a couple different brain areas, including the nucleus accumbens and the ventral tegmental area, when neurons in that part of the brain, and neurons in that part of the brain primarily use dopamine to communicate with each other, dopamine being an excitatory neurotransmitter. When opioids bind with receptor sites on the surface of those neurons, that essentially increases the rate at which those neurons fire. That feels really good. We sometimes refer to those brain areas together as the pleasure center of the brain. So if we were able to stick an electrode into your brain, in that area of your brain, and activate those neurons, it would feel really good. You might even feel a sense of euphoria. So when people use opioids, they bind to those receptor sites, those neurons fire at a faster rate, and it tends to feel really good. It also has the effect of modulating experiences with pain. So let's think back to Andy. When Andy was using opioid pain relievers prescribed by his physician, there were physical changes on the surface of those neurons, and his body adjusted to elevated levels of opioids in his central nervous system. Sometimes you'll hear people refer to addiction as a brain disease, and this is the primary process that people are referring to, these neurobiological changes that occur. Now, when people stop taking a substance, because the brain has physically adjusted to increase levels of that substance, people experience withdrawal symptoms. So because my brain has adjusted to increased levels of caffeine, when I stop drinking coffee, I experience all those withdrawal symptoms, same as Andy did when he would run out of his opioid pain relievers. And in this way, there's a degree to which this process kind of goes out of people's voluntary control. Those changes have occurred and lead to withdrawal symptoms and cravings, where people physically need the substance. Withdrawal, for example, from chronic, especially high levels of alcohol use, because of the neurobiological changes that have occurred, can even be deadly. And this is why when people are in recovery from alcohol use disorder, medically supervised detox is really important. So there are these neurobiological changes that occur from chronic substance use that make recovery from substance use disorders challenging. So one really important component of treatment for people who struggle with substance use disorders then are medications that can ease withdrawal symptoms, and medications that have other effects. So in the treatment for opioid use disorder, a common medication are what are called opioid agonists. These are medications that bind to the same receptor sites that opioid pain relievers or other synthetic opioids such as heroin or fentanyl bind to, and can ease withdrawal symptoms and aid people physically through the recovery process. They can also lead to reduced cravings and urges and reduced use as well. But in addition to having neurobiological impacts, substance use is also maintained through psychological and behavioral processes. So again, think back to Andy's case. When he would take opioid pain relievers and heroin, he would experience a reduction in physical pain and a reduction in psychological distress. Think of the things that, when you do something that leads to you feeling less physical pain or less psychological distress, or that helps you feel better, you're more likely to do those things again in the future. That's the basic behavioral process of reinforcement. Problematic substance use is maintained not only by neurobiological processes, as I talked about earlier, but also by psychological and behavioral processes, primarily a combination of positive and negative reinforcement. So it's neurobiological processes and psychological and behavioral processes working together to maintain substance use over time. Treatment for substance use, as I mentioned, at times, depending on the substance, often involves medication. And modern substance use treatment adopts what is known as a recovery-oriented perspective, where the focus is not merely on helping people maintain sobriety, but is on helping people increase well-being and quality of life. Helping people with housing, with employment, things that people might often struggle with as a result of substance use. Here I want to note what is maybe not effective in reducing substance use. I'd like you to consider that if you think of all the mental health problems that we're talking about in this unit, that the only psychological disorder, the only mental health problem that we attempt to address as a society through the criminal justice system is substance use disorders. You can't go to jail for engaging in hours of compulsive behavior as part of obsessive compulsive disorder. No one's going to arrest you and send you to prison for feeling so depressed that you lay in bed all day. People who experience delusions as part of schizophrenia don't go to jail for that. But one way as a society that we have attempted to reduce substance use is by criminalizing that behavior. That approach of criminalization for substance use has largely been ineffective and rather counterproductive. From an ethical perspective, I feel compelled to point out that criminalizing behavior that is part of mental health problems is grossly unethical. It violates core ethical principles related to benevolence and justice. It's also worth noting that the criminalization of substance use disproportionately affects Americans of color. Black and Latino Americans, for example, are disproportionately incarcerated for substance use and disproportionately arrested for substance use. This is despite research that shows convincingly that white Americans and African Americans and Latino Americans use substances at the same rates. That's true of all of the substances that we've talked about so far. Rates of use are the same across various race and ethnicity groups in the United States. But as I mentioned, African Americans and Latino Americans are disproportionately likely to be arrested and incarcerated for their substance use. So not only is the criminalization of substance use ineffective at actually reducing substance use, rates have not decreased as a result of that. Overdose deaths have only risen over the last several decades. But those efforts are also unjust. They disproportionately negatively impact and result in the incarceration of people of color. It's also worth noting that the criminalization of substance use only serves to perpetuate and inhibit substance use problems and inhibit recovery. As a result of incarceration and a criminal record, people might struggle gaining future employment, renting and gaining housing, perpetuating struggles going forward, creating barriers for people developing lives of high quality of life rather than helping people do that. And it doesn't actually facilitate access to treatment either. Treatment for substance use needs to be comprehensive and recovery oriented to help people medically, to help people psychologically, but also to help people with housing and employment. So I think we pretty much covered most of the important topics that I wanted to related to substance use disorders. If you have any lingering questions, please feel free to send me an email. I'm happy to also meet with you and talk more about substance use disorders, the opioid addiction crisis, the causes and maintenance factors related to substance use disorders, and treatment related to substance use problems as well. So the next step will be to take a quiz on the content of this lecture. A lot of what I covered, especially some of the key terms and concepts and diagnostic criteria, is briefly covered in the reading for this unit as well. So after you take that quiz, you'll be watching a documentary about the opioid addiction crisis and then completing a discussion assignment about that.